This week's content is IV Starts, and it is located in Chapter 29 of your Skills textbook. Your objectives are to identify the appropriate veins that are used for venipuncture, also identify the proper equipment that is needed, describe assessment and procedural steps that need to occur before, during, and after IV catheter insertion, and you will demonstrate safe and proper steps for venipuncture while in lab. Communication is very important in providing patient-centered care. You want to speak directly to the patient and answer any questions that they may have as honestly as possible. Let them know that yes, they will feel a pinch, a stick, because you are using a needle in order to puncture the skin, but it should not remain painful. They are to let you know if they have pain after the IV has started, because that might be a sign of a complication. Talk them through the steps, answer any questions that they may have. I would also ask them if they have ever had an IV before and what that experience was like, because if it was traumatic to the patient, you may have to spend some extra time letting them know what you are going to do to make sure that doesn't happen again. You may, if you have a patient that's especially anxious, you may need to speak to the provider about possibly getting an order for some type of skin, some type of emulum cream that may make the needle stick less uncomfortable for the patient. We used emulum cream quite a bit when I worked in pediatrics. It has to sit on the skin for at least 30 minutes, and it's just something that will numb the skin a little bit. They'll still feel a little bit of a stick, but it helps to numb the skin. So that's something that you can get an order for if need be. So just communicating well with your patient, making sure that they are comfortable throughout, talking to them while you're doing it, trying to get their mind off of it using distraction. Also, you want to make sure that you pay attention to the patient's cultural and linguistic needs. Make sure that they understand what you're trying to teach them. Also, you want to know that pain is expressed differently in different cultures. So encourage the patient to let you know what's going on so that you could help them. In the end, you want to make sure that the patient is aware of all aspects of IV therapy, what to expect while you are inserting it, what the goals are, and how to take care of it afterwards. A vascular access device, or VAD, is used to access a vein. VADs can be peripheral or they can be central. Peripheral VADs are the ones that we will focus on in this lesson. They are winged butterfly needles, which you see at the bottom of the page, and they could be short peripheral devices, which you will learn how to insert in the lab, or they can be midline catheters. I don't have a picture of the midline catheter, but you may see them in clinical. Midline catheters are used if a patient requires IV access for longer periods of time, for example, 1 to 4 weeks. They are placed in the antecubital fossa, and the tip usually lies just below the axillary line, so they're pretty long, about 3 to 8 inches in length, and a nurse who has been specially trained can insert midlines. They are threaded into the larger veins of the upper arm, so there's more hemodilution. However, you are still only allowed to administer the same types of solutions and medications that you would administer through a short peripheral IV. So these medications and fluids still have to have an osmolarity of less than 900, and they can't have any extremes in pH. And again, you may see the midline catheters in clinicals. So central VADs, which you will learn more about next semester, are PICC lines, tunneled and non-tunneled central lines, or implanted vascular access ports. You may know them as portacaths. So the top illustration is a angiocath or an over-the-catheter needle. This is your short peripheral device, and we'll talk a little bit more about that on the next slide. And then B is your winged butterfly needle, which you may have seen if you've ever had a venipuncture for a blood draw. First image on the left is of the over the catheter needle or angiocath. The needle or the stylet guides the puncture, and it extends over the tip of the catheter. The catheter is made of a plastic-like material, and that's what actually stays in the vein. The stylet or needle is going to be removed once the catheter has been threaded fully into the vein. After the catheter, you see the hub or and this one actually has wings. All of them don't have wings, but the hub is usually the part that's colored. Beyond the hub of the needle, you will see the flashback chamber. It's a small space at the hub of the catheter where you can actually visualize the backflow of the blood that happens when there's increased pressure as the stylet enters the vein. And so it's a good day when you look into the flashback chamber and you get blood, then you know you're actually in the vein, and you can go ahead and thread your catheter the rest of the way. And then the last part of this angiocath is you could see the safety needle cover. So all catheters should have some type of safety. This one is one that where the stylet or needle would be enclosed in that safety needle cover when you're done. The ones that we will practice with mostly in the lab have a button that you have to push and activate, and it will automatically draw that stylet back into the covered sheath of the angiocath. You want to use the shortest length of catheter and the smallest gauge that is appropriate for the type of therapy that you're trying to provide. So the catheters are angiocaths are color coded. The sizes are 14 usually to 26 gauge, and the smaller the number, the larger the diameter. In the reverse, the larger the number, the smaller the diameter. So the 14 gauge would have a larger diameter, and the 26 gauge would be a smaller diameter, would be something that we would use on an infant or a really small child. The smaller gauge will take up less space in the vein, which will allow for blood to flow around the catheter. Smaller gauges also cause less trauma when they are inserted, but of course we need to choose the size of the catheter based on our patient. Number one, the condition of the veins, if the vein will accept a larger gauge should we need it, and also based on what our patient needs to have infused. So a 14, 16, or 18 gauge IV catheter is used for trauma patients, because oftentimes they have to have fluids and blood or blood products infused rapidly, so we need a larger diameter so that those patients can get those fluids and the blood quickly. We may use a larger gauge catheter also if a patient's going to have surgery, because during surgery sometimes you don't know what might happen, so they may need a larger gauge catheter. So you may see an 18 or a 20 at the minimum. We always need a minimum gauge of a 20 if if an adult is going to need a blood transfusion. Any smaller, sometimes the cells can be lysed. So a 20 is usually the minimum for adults. And in general, for most standard infusions, a 22 or 24 would be okay. 24 more so for pediatric patients, or if you have an elderly patient who has really small veins, you may want to use a 24. But again, the size that is chosen will depend on the size of the veins of the patient and what the therapy is, what you need it for. Again, patients going for surgery or procedure, you want to have at least a 20. If you can accommodate an 18, even better. Okay, and let's look at the image on the far right. That's of your wing-tipped butterfly, or some people just call it a butterfly needle. We can use this for infusions as well. They're really easy to insert. They're my favorite when drawing blood because they're just easier to insert and easier to handle because you just pinch those little wings up and insert them into the vessel. But if you're using them for infusions, you can only use them for one infusion, or if you're just needing to give the patient an IV medication, it's just you can only use it one time and then you have to remove it because they are more likely to infiltrate. You may see these, the other time that you might see these used would be in infants. Now we're going to look at some of the equipment that's needed for an IV insertion. We will start with the IV start kit. It has all the basic materials that you would need. So you would find a tourniquet, 2x2 gauze, roll of tape, Tegaderm to secure the catheter. You'll find an alcohol pad and or chloroprep or chlorhexidine. And know that chlorhexidine with alcohol is the standard of practice. It's really a really good antiseptic. It has a residual effect on the skin for up to 48 hours. You have to use it for at least 30 seconds. So you're going to use mechanical friction on the skin back and forth, side to side, and it has to completely dry before you puncture the skin. You could also use just 70% alcohol on the skin alone, circles inner to outer for 30 seconds. If a patient's allergic to alcohol or chlorhexidine, you could use povidone iodine in a swab stick. And with that, you're using concentric circles as well, beginning at the venipuncture site and moving outward. This would have to remain on the skin for at least 2 minutes, and it would need to dry. And you never use alcohol on top of iodine because you will just lose the effects that you just tried to put into place. So if you're using the betadine or povidone iodine, you just want to be patient. You know that it has to stay on the skin for at least 2 minutes and dry completely. With any antiseptic that you use, it's really important that all of them dry, because what could happen is that when you puncture that skin, the antiseptic can be tracked into the vein and cause phlebitis. So very important to go ahead and take the time to let all of them dry. When it comes to, I mentioned that there's tape and a Tegaderm usually in the kit. So stabilization of your catheter once you have it in place is really important. Number one, you worked hard to start that IV. And having a catheter that's not moving around in that vein is going to decrease the risk of phlebitis. It will decrease the risk of infection because if there's any type of microorganism that's on the skin, it could track up the catheter and go into the bloodstream. It could all making sure that the catheter is stabilized decreases catheter migration and catheter dislodgement. Know that there are also special engineered devices that are sometimes used in facilities like stat locks to stabilize the catheters as well. Other equipment that you might use would be, well, actually, let me go back. Inside your IV start kit will be a label, and on this label, you would put the date that the catheter, the IV was started. You would put date and time. You'd also put the gauge on there. You would put your initials as well. Other supplies that you would need would be that you would have to grab that's not in a kit would be extension tubing. You'd also want to grab a saline flush to make sure that the catheter is actually in the vein once it's stabilized. And you would, of course, need to get the appropriate sized IV catheter. Other optional equipment might be lab specimen collection materials if the provider wants labs drawn on the patient, usually at admission, or if something changes in your patient's status, you may start an IV and draw blood at the same time, and you'll see nurses do that. You may also, your facility may also require you to cover your needleless access ports on your IV or on your at the end of your saline lock with passive disinfection caps or Curos caps, so you may gather that as well. And your patient might require some type of joint stabilization device if you're inserting the catheter in an area of the wrist or the area of the antecubital space. If that's the only option that you have, you may have to use some type of stabilization to keep that joint straight. And then if you have a patient who's confused, or if it's a child, you may also have to use some type of sight protection device. And the image that's on the very bottom of the screen with the hand, that's an example of a sight protection device that's available. So on this next slide, these are things that I want you to think about as we are going over the next slides. And at the end, you should be able to answer these questions. So when you come on, the previous shift nurse lets you know that the patient's IV has infiltrated and a new IV is needed. So just think, what information would you need about the patient before starting the new IV? How do you determine which vein to use for the insertion, and what factors might hinder a successful IV insertion? So when we finish, you should be able to answer these questions. First, we will focus on the use of a tourniquet. So the purpose of the tourniquet is to cause venous dilation by impeding blood flow. It is placed 4 to 6 inches above the proposed insertion site. It should be tight enough to impede venous flow, yet maintain arterial circulation. So the first thing that you're going to do after you tie your tourniquet is to assess for a pulse distal to the tourniquet. If you don't feel pulse, it means that your tourniquet's too tight. It's affecting arterial circulation, so you need to loosen it. Some things to keep in mind are that the elderly or patients who are on anticoagulants need to have their tourniquets tied loosely or don't use one at all. With the elderly patients, their veins are very fragile. So tying a tourniquet too tight will cause the veins to blow, and I learned that the hard way. So just make sure that, again, it's loose, or you may not need a tourniquet at all, or you may just want to use a blood pressure cuff. So blood pressure cuffs are good for patients who have fragile skin or who have hairy skin. You can pump the cuff up to about 50 millimeters of mercury. Also, if a patient has fragile or hairy skin, you could just place the tourniquet on top of the clothing, and that would help to protect the skin and not pull their hair. So venous dilation, do's and don'ts. I'm sure you've seen and you might have experienced a lot of different things. So do's, what you should do is position the extremity lower than the heart to let gravity help you out. Just kind of let it hang. If you try a tourniquet and you still don't see anything, you can let the arm sort of hang down off the side of the bed. You can have the patient open and close their fist, lightly stroke the vein, or apply a warm towel to the extremity for about 10 minutes. Some things that you don't want to do is apply vigorous friction. You also don't want to slap the vein or hit the vein. What that can do is cause venous constriction. It could also cause bruising and a hematoma. So those are things that you definitely want to avoid doing. This is an image of some of the common veins used on the arm. Veins on the dorsal and ventral surfaces of the arms are preferred in adults. So you don't have to memorize the names of these veins. I just want you to be familiar with the location of them. This on the first image These are the metacarpal veins of the dorsum of the hand. They are easily visualized. You can usually you can see them, you can palpate them, and they're usually accessible. What you want to do is find one that's straight and that can accommodate the length of your catheter, because if you look at this particular hand, these veins branch quite a bit. So I would only choose one that I would choose the straightest one. Sometimes what you also see on the hand will be valves, which are it will look like little lumps on the vein. So you want to also avoid areas where those valves are, because you may have a difficult time threading your catheter if there's a valve there. So you want it to be straight. You also want want the vein to be spongy. And just as a guide, you want to choose a site from distal to proximal, so work from the hand upward, because if you start out higher on the arm, then if that site infiltrates, you can't go below. You can go higher, but you can't go below. So that's why we say try to start distal and work proximal. You want to also, actually, let's go back. Let's look at the middle image. In this middle image, you can see the cephalic vein, the accessory cephalic vein, and the antecubital vein. It also has the basilic vein there. Those veins are visible. They look like really good veins, but the cephalic and the median cubital vein, the ones that are around the antecubital area, you want to reserve those for venous blood sampling and for PICC lines or midline catheters, if at all possible. If I were looking at this arm and trying to assess which vein to use, I would start out with the basilic vein. It's usually a good choice, but you want to keep in mind that this is one vein that will move easily, so it's going to be important to really stretch the skin and stabilize the vein before you access it. And then and then the last image shows the cephalic vein again, and then the basilic vein. So there's another question here. You want to avoid areas that are compromised. And what are some of those areas of compromise? Any area where you can see bruising, any areas where there's infection or open wounds, areas where there's been an infiltration. These are areas that are already compromised, so you want to avoid them because it's going to be difficult to assess for any complications should they happen if you use these particular areas. A bruised area is already damaged. Definitely you don't want to use these areas. You also want to avoid any hard or sclerosed vessels. So when you're palpating, you push down, you want those vessels to be spongy. Push down, it should come right back up. I mentioned avoiding areas where there are valves, because you may have a difficult time again threading those catheters. You want to avoid the hand veins in older adults. They're more fragile. There's just a greater risk of infiltration if you use these vessels. Elderly patients also have decreased subcutaneous tissues in their hands, so it tends to be harder to anchor those veins. Those veins tend to move a lot, so you want to try to avoid the hands. You want to also avoid the ventral surface of the wrist, so the inside of the wrist. This is an area that is particularly painful. If you start NIV there and you have a greater risk for nerve injury, you'll see usually respiratory therapy, they're the ones who draw the blood gases, and they'll draw blood gases in this area. They're trying to have been specially trained on how to do it. Nurses aren't usually, nurses who work just on regular med-surg floors aren't usually trained to do blood gases, so they know they're trained on where those nerves are, so they know how to avoid them and avoid injury. Other areas that you want to avoid would be the lower extremities in adults, because there's a greater risk for thrombophlebitis when you access the lower extremities. If I remember a long time ago, I had a patient, he was, he had end-stage renal disease, so he had no vessels, and I had to draw some blood on him, and I couldn't find anything, but he had some good veins in his feet. So I had to call a doctor and talk to him and get an order, and I was able to get an order to draw blood there, but he had nothing. Um, he ended up later on getting a PICC line inserted, and that's a central line. You'll learn a little bit more about that next next semester, but it requires a nurse who's been specially trained on how to do that can insert those types of lines. So otherwise, you don't use lower extremities in adults. Children, sometimes you can. If you work in pediatrics, you'll learn how to do that. So other considerations, choosing a site that doesn't interfere with activity. We want our patients to stay as mobile as possible, so we try not to use the same side in which the patient has their dominant hand. However, I'll tell you sometimes you don't have a choice. The patient may not have good veins on their opposite side, so you may have to use the side where they have their hand dominance. We try not to if we can. You want to also avoid the same side that a patient might have had a mastectomy with lymph node removal, and or either after they've had a side where they've had some radiation to, because there could be reduced lymphatic drainage, which can lead to increased risk for infection from a needle stick. You want to also avoid the side where there's an AV graft or fistula for dialysis. There's a risk for clotting and bleeding. There's also a risk for infection. And when patients have these AV grafts or fistulas, we want to protect it. This is their access to have to, this, is basically where they get their dialysis, where the work of their kidneys is done. So we want to really preserve that, and we don't use those limbs, blood pressures, or IV sticks or blood draws. We also don't want to use the affected side in which a patient had a CVA or stroke on, because, or area where there's side where there's paralysis, because there tends to be decreased venous return in these areas. You want to be cautious of hitting nerves as well, and I talked about this a little bit with the ventral surface of the wrist. You also have the radial nerve, which can be is at the base of the wrist on the side of the thumb. So, and it extends up the thumb. Sometimes there's a vein that's visible on the side of the thumb, but you really want to be careful and try not to use that unless you've have a lot of experience and you really know where the vein is. Additionally, you want to avoid, be careful of the median nerve, and the median nerve is in the center of the antecubital fossa. So if you end up using the median cubital vein or the accessory cephalic vein for a blood draw, then if you miss it on the first time, you want to be careful about trying to redirect your needle, because sometimes when nurses get experience, they you may go just on, you may be just on top of the vein, or you may be under the vein, and sometimes you'll see them sort of redirect the needle, but you really want to be careful in the antecubital fossa because the median nerve is in the center and you want to hit that nerve. More on site selection. So there's been improved technology that can help us with finding a good site in the way of vein finders. There are different vein finders out there. There are transilluminators, and they use this high intensity light that's directed down into the subcutaneous tissues. The blood that's deoxygenated will absorb the light and appear darker in color, while the subcutaneous tissue reflects the light. So you will see the subcutaneous tissue will be illuminated. There's also near infrared imaging devices that are also can be used to help you find veins. While you're out at your clinical sites, pay attention to the nurses if they use those, or if they have an IV team that will do the starts. Kind of see if you can go in the room when they're using them so that you can see this technology, because sometimes the patient, of course, we all have veins, right? But you can't see it and you can't feel it because they may be a little bit deeper. So this type of technology has helped to improve outcomes, but you want to also make sure that you try to feel for the vein and you don't forget to release the tourniquet. And I didn't talk about this when we were on the previous slide on talking about tourniquets, but you never leave a tourniquet on for more than a minute, because again, you're impeding that venous blood flow. So you want to just 1 minute, put it on, palpate, look, feel for your vein, and then take it off while you get the rest of your materials ready. Well, this will make a little bit more sense when we get into lab and start going through the procedure, but you always want to make sure you don't forget to release the tourniquet at the appropriate times. So complications. Now it's important to recognize the signs and symptoms of complications that might happen while your patient is undergoing IV therapy. One that we've talked about before is infiltration. Infiltration is simply results from the IV catheter migrating out, moving out of the vessel. So it's in the tissues. It can cause pain, swelling, redness. There can be blanching. The skin usually feels cool to the touch. And another, I didn't mention this before, but when there's an infiltration that is caused by a vesicant, a highly irritating medication or fluid, it's referred to as extravasation. And medications that are typically vesicants would be things like chemotherapy. There are other medications, of course, but that's just one example. They can be very irritating. They can cause tissue sloughing, blistering, and even necrosis of tissue. So if your patient has an infiltration of a medication that you're giving that's considered a vesicant, and you'll know that when you look it up, you need to let the provider know, because oftentimes they'll have to order some type of therapy in order to protect the tissues. Okay, so that's infiltration. The next type of complication that we need to talk about is catheter occlusion. So a catheter occlusion can happen for several different reasons. You'll know that the catheter is occluded when you go in to assess for patency and you can't flush it, you meet resistance. Again, if that happens, the first thing you want to do is make sure that the clamp that's on the saline lock is actually open. That's open and you still meet resistance, then there's some type of occlusion. Sometimes it's positional. So positional meaning the catheter is possibly in an area of flexation in the area of the wrist or the antecubital space, and maybe the patient bent that joint and so it kinked off the catheter. It could happen because there's a kink or a knot in the tubing. They rolled over on it. The patient rolled over on it and didn't realize it. It could also happen because there's a clot in the catheter or there's some precipitate formation from fluids or medications that were given. So what do? We're going to check our tubing first. We're going to, if we think it's positional, if our catheter is in an area of flexation, we're going to try to have the patient reposition that extremity and see if we're able to flush it. Never force a flush, because if there is a clot there, a thrombus, it could easily become emboli if you force the flush. So don't ever force it. If it doesn't, if you're not able to flush it gently, then you need to remove the catheter and place it somewhere else. Okay, And I think I mentioned if there's a kink or not in the tubing, then just kind of follow the length of the tubing and see if there's a kink, and then you can straighten it out. The next type of complication we need to cover is phlebitis. The image that's on the far right is of phlebitis. So there is inflammation in the vein. It can be caused by a lot of different things. It can be caused by irritation from a foreign body. Maybe the IV insertion was traumatic, and it could be caused if a piece of the catheter actually was removed during the forceful insertion. It could be caused by an irritating medication, injury to the vessel during insertion, infection because of bacterial contamination. If the catheter is too large for the vein, it can cause phlebitis. Additionally, if the IV catheter itself was not properly secured and it's just moving, that movement within the vessel can cause irritation to the vessel wall. And you will see the patient will have pain. You'll see redness. There will be warmth, swelling, induration, or when you palpate, you may feel it's referred to as a palpable cord, or like a hardened area along the vein. What you have to do is notify the provider. And the provider, there's different types of phlebitis. You don't have to diagnose if it's chemical, if it's mechanical, or if it's bacterial. What you would have to do is just notify the provider, and they would let you know based on what they think is going on what to do. Oftentimes, you're going to end up removing that IV and placing another IV somewhere else. Okay, infection. Infection will manifest as pain, redness, swelling, purulent drainage, and the patient will oftentimes have fever. In this case, of course, you notify the provider. You're going to remove the IV catheter, and oftentimes you'll culture the area to see what the infectious agent happens to be. Another complication would be hematoma. Hematoma is simply bleeding under the skin that's caused by trauma to the vessel wall. What you will do in this case is remove the IV catheter, elevate the extremity, and apply pressure, monitor for bleeding and neuro or muscular dysfunction. Nerve injury. Again, we want to avoid those areas like the wrist, the ventral surface of the wrist, and we want to avoid the middle part of the antecubital fossa. But if there's nerve injury, the patient will have tingling, paresthesia, so they'll have shock-like pain, they'll have tingling and sort of that pins and needle sensation. They could have burning, or they could have numbness on insertion. What you do is notify the provider, stop the insertion, remove the device, and monitor their neurovascular status. And the provider would let you know what to do if there's anything extra that you need to do other than monitoring. So on the next two slides, you will see an infiltration scale. This is used to grade how severe the infiltration is, and it's important to do this so that you can monitor how it's progressing, if it's getting better, evaluate if it's getting better over time. I don't want you to memorize this. I just want you to know that there is a scale on which we grade infiltrations and we grade phlebitis. This is something that the scale may be a little bit different depending on the facility that you're in. So as a new nurse, it would be something that you would want to write down in your little notebook, just in case your patient has phlebitis or infiltration. You can document it appropriately, assess and document it appropriately, so you can so that everyone knows what's going on with the patient if they're improving where they started from. So again, not something you have to memorize. I just want you to know that it's something that exists, and it's something that you need to use and do. Okay, delegation and collaboration. So this is on IV insertion. We cannot delegate it to nursing assistive personnel. For LVNs in the state of California who have taken the IV certification course and passed it, they can start IVs. For NAPs, they would just notify us if there is any complications with the IV site that they saw or leaking, anything that the patient complained about related to the IV. They let us know if it becomes wet, if they're assisting the patient in taking a bath or a shower. They would let us know so that it could be covered appropriately, so that it does not get wet. And of course, they would let us know if the IV pump is alarming or if the bag of solution is low. Recording and reporting. When you document, you'd want to document the number of attempts. Now, there's usually a rule where one nurse can only attempt an insertion twice, so usually a maximum of 2 attempts. If you're not able to get it, then you have to check with one of your colleagues, check with another nurse, and ask them if they wouldn't mind coming in and trying to start an IV on your patient. As a student, you may only get 1 attempt. It just kind of depends on the patient and depend on the nurse that you're working with. So you're going to document number of attempts, the site. You're going to document, of course, the gauge of the IV catheter as well. If you started fluids, what they were, what the rate is, how the patient responded. If you're using an IV pump, you document that as well. I talked about the fluids, the amount, that it was patent when you flushed it. You would report the IV the size, the insertion, how the site is doing to the oncoming nursing staff. And if there are any complications, of course, you would have to document that and report them to the healthcare provider. Special consideration, so we would teach our patients the signs and symptoms of all of the complications. We'd want to teach them how to walk if they have an IV pole. Put it in the and if the IV is in the hand, you'd put it in the opposite hand. So helping them ambulate, helping them perform their activities of daily living with their IV and still protect it would be something that we would need to definitely teach them how to protect it as well, not to get it wet. When it comes to our pediatric patients, typically anything that's potentially traumatic to the patient, so venipunctures, things like that, are not done in the patient's room. The patient's room is considered a neutral space, a safe space, especially for the young ones, teenagers. I mean, you probably would do it in their room, but for the little ones, we don't do it in the room. We would take them to what would be considered a procedure room to do these types of perform these types of interventions. For infants, there are 4 different scalp veins that could be used for as IV sites, and also the dorsum of the foot. And again, this is just in infants. And typically, you're going to use anywhere from a 24 to a 26 gauge in infants and neonates, and 24 or 22 in children. Local anesthetics can be used, like the Immelacream I mentioned before, in distraction to minimize the distress, because no one likes needles, right? These patients, we would have to get help with. Our pediatric patients, we need help inserting an IV on them, so you'd have to get an NAP or one of your fellow nurses to help you. And then with older children, if possible, if they have multiple sites that are possible, you can let them help you select the site just to get them involved. With our elderly population, just remember their veins are fragile, their skin is fragile, so we may not use a tourniquet at all, or we may put the tourniquet on very loose, or use a blood pressure cuff. Additionally, we would place whatever we're using on top of their clothing in order to protect their fragile skin, avoid the veins of the hand as well. And then monitor them if they're receiving any IV fluids, because they're at risk for fluid volume excess. So we would monitor them closely. Changing a dressing is skill 29.5. Dressings are changed every 5 to 7 days. If it's a transparent, semi-permeable membrane dressing, so a Tegaderm, we change every 5 to 7 days. If it's gauze or gauze under a Tegaderm, it's changed every 2 days. We would also change a dressing if it was loose or wet or soiled, or if the integrity was compromised in any way. And while you're removing this dressing, you would remove it the same way that you would remove the dressing to discontinue the IV. So stabilizing the catheter with your non-dominant hand while removing the dressing or the gauze in the direction of insertion so you don't pull out the catheter. And then you would also perform skin asepsis. So you may use chlorhexidine, or you may use betadine if the patient's sensitive to chlorhexidine. And again, you want to let those all of those agents dry first, and then you would reapply your dressing or your engineered stabilization device. The dressing change cannot be delegated. LVNs can do it if they've had the course. The NAP would again report any complications to you if they notice that the dressing is loose or it's moist, or if they need help with trying to protect the IV site during hygiene or activities of daily living. They would report that to you as recording and reporting. We would document everything that we did, so the time that it was performed, why we performed the dressing change, what we used. We would assess the patency of the IV after the dressing change, just in case the catheter moved at all, and of course we'd have to document that, what the site looked like, clean, dry, intact, no redness, swelling, drainage. We would report to the healthcare provider, of course, any complications that that might have occurred as well. We have to teach our patients to notify us if they notice that their dressing is wet, soiled, or loosened. If this is the case, then the integrity is definitely compromised, and there's a chance that microorganisms can migrate up through the skin and up the catheter. So we really need to be mindful and change dressings if that happens. With our pediatric patients, they might not be able to fully understand a verbal explanation, so it's important to use a toy, or and make sure that the parent is present when we are trying to explain procedures. That will help oftentimes to decrease their fear and increase their cooperation. So you could practice performing, sort of simulating the procedure on their toy or doll first. We always want to protect the catheters of children, pediatric patients, from dislodgement, so you would use some type of special engineered device to do that. Arm boards are sometimes used. When you go to your pediatric rotation, try to pay attention to what they use in the facility. Also, I don't think I mentioned this earlier, but when it comes to chlorhexidine, you can't use it on infants under 2 months of age. Also, dried povidone iodine should be removed with saline wipes or sterile water in infants younger than 2 months, or in pediatric patients with compromised skin integrity. So just keep that in mind. When it comes to our elderly patients, since they tend to have fragile skin, you want to prevent skin tears. So using skin protectant before applying tape is often helpful. And when you remove tape, use adhesive remover. Be mindful that sometimes infiltration can go unnoticed because there's a decreased elasticity of the skin and loose skin folds. So, and also the patient may have decreased tactile sensation, so they might not have that pain if they start to have an infiltration. So watch the IV sites on your gerontological patients very closely. If you happen to go into home care and your patients are receiving IV therapy, you want to teach the patient or the caregiver about signs and symptoms of complications of the IV. You want to make sure that they know how to protect that site. They use hand hygiene. If the dressing becomes compromised or the catheter comes out, make sure they know who to call should that happen and what to do. So I'll quickly review discontinuing an IV. Some of you probably have had the opportunity to do that by now. We would discontinue it when the therapy is finished. Also, if there's a complication, we would have to discontinue it. You want to make sure that you follow infection control guidelines while removing the catheter. So, another thing to note is that if a patient's on anticoagulants, because you're going to have to place pressure at the site for at least 5 to 10 minutes afterwards. And what we do is remove the dressing again towards the direction of the insertion site while stabilizing the catheter with our non-dominant hand. Then once the dressing is removed, you're going to place a sterile dressing over the site and then remove the catheter slowly and steady, keeping it parallel with the skin. And once that catheter is removed, once you take it out, you have to actually visualize it, look at it, and make sure that it's intact. So that and if it's not intact, then you would have to notify the provider, because if a piece has come off, then they would need to do an x-ray because it could become emboli. Delegation and collaboration. Discontinuing the short peripheral IV cannot be delegated to an NAP. LVNs, of course, can do that, can take them out with their course, and we just instruct the NAPs, of course, to notify us if there's any complications after the catheter is removed. If they notice any bleeding, they should let us know, and to let us know if the patient complains of pain or they notice any redness at the site.